Hello everyone, and thank you for joining us today. I am Mathieu Raillard. I'm an anesthetist, and I will talk today about anesthesia safety and in particular about strategic case preparation for dogs and cats. Now, I have one regret in life. I started skydiving a bit less than 2 years ago, and I should have done that much earlier. You may wonder what link exists between anesthesia and skydiving, and there are actually many. Most people will perceive skydiving as a dangerous activity. And what if I told you that actually the risk of dying during skydiving is way lower than the chances of dying during anesthesia for our dogs and cats? The injury rate in skydiving is lower than the lowest mortality rate in our animals, and the fatality rate during skydiving is below 1 on 1,000 jumps. So why is there such a huge difference in mortality and in risk in general? And what can we take in vitro anesthesia from skydiving? I suppose most people jumping from a flying plane will be well aware that they are taking a risk, and therefore, at each and every single jump, they will apply rigorous safety protocols for every jump and regardless of the number of jumps they have done. No, as experienced vets and vet nurses performing anesthesia, the reality is that we tend to enter a routine once we have done some anesthesia, and therefore we may take some shortcuts that put our patients at risk. Before starting, I'd like to mention that although RWD is sponsoring this webinar, they had no involvement in the content. The content is all supervised and done by me. As mentioned, I'm the current president of the Association of Veterinary Anesthetists, and I serve as an associate editor of the Journal of Veterinary Anesthesia and Analgesia. I am currently a senior lecturer in veterinary anesthesia and analgesia at Murdoch University in Western Australia, and I don't believe that any of those involvements represent a conflict of interest in the topic discussed today. So I'd like to start the chat today quoting Charles Rootman, who is the Safety and Training Manager of the Australian Parachute Federation. In skydiving, we can't rely on luck, nor should we rely on the vigilance of others alone. Safety is a collective effort. This certainly applies to vet anesthesia. And although you may not be the ones primarily involved with anesthesia and anesthetic management, as technicians, veterinarians, nurses, or anyone surrounding the cases, you all have a role to play in safety. Is that the only parallel that exists between vet anesthesia and skydiving? Well, probably not. Actually, both disciplines involve a significant risk and require careful preparation. There are very strict safety protocols in skydiving, similar to the safety measures that should be applied in anesthesia to minimize risks. And in both disciplines, people or users, skydivers, vets, nurses, need to make split-second decisions. And those decisions will likely have an impact on the rest of the events. Now, believe it or not, when we have not thought about a possible problem and a possible risk, as humans, we make terrible decisions, and that increases the risk. And therefore, in both disciplines, the preparation is key. Now, let me discuss timeline. You are probably all familiar with the timeline of anesthesia. It all starts with preparation. After a careful preparation, which I hope will be even more careful after our chat today, people pre-medicate the animals. The goal of the pre-medication, well, there are multiple goals to pre-medication, but the most important ones are to reduce stress and anxiety, induce some sedation, and start the preemptive analgesia protocol of the cases that are necessary for the procedures they are undergoing. Reduce the amount of drugs that will be needed in the successive steps of anesthesia. and overall smoothen all the anesthesia, hopefully including the recovery phase. Following premedication, anesthesia is induced. It's the transition between a conscious and an unconscious state of the animal. During that phase, we generally intubate the trachea and make sure that we can take control on everything, that animals can be monitored, and that we can control the breathing, monitor it, and that we can have some action on the cardiovascular system if needed. Following induction of anesthesia comes the maintenance phase, maintenance during which the procedures happen. And finally, before, at the end of the maintenance phase, once all the procedures are carried, comes the recovery phase, which is one of the most important ones in anesthesia, and we will discuss that in a little bit. No, I'm not sure how many people have ever done skydiving before. So apologies for those who are already experienced. I will go through a very simple timeline of skydiving and compare it to anesthesia. In skydiving, there is also an extensive preparation phase. People need to know everything about their jump before they actually board the plane. Then they board the plane takes off and brings the people to about 12,000 feet, which is around 4,000 meters. Similar to premedication, like the ascent looks like a premedication where we get where we need to be. Once the pilot is happy with the altitude and with the location of the plane, because we should drop the skydivers where or in proximity to the place they will land, then equivalent to an induction, the door opens, people jump. And then comes the fast and fun thing, the free fall. People are falling in the air at a speed of about 50 meters per second. That lasts about 1 minute during which it's essential to monitor altitude. During that fall, people do different things. You can do free fly, you can do group, figures, etc. There are different options, a bit like us and our surgeries or our medical procedures. And finally, at a set altitude, we need to deploy the canopy, fly under it, control the landing, and land safely. So the timelines kind of overlap. No, because we have limited time today, I selected key focus areas and essentially 5 critical points that are relevant to both skydiving and anesthesia to enhance safety. The first point we will talk about is the information we need before even thinking about anesthetizing an animal or jumping from a plane. The second point we will discuss is the planning and the preparation overall of the cases and of the skydivers. We will then discuss the importance of the equipment. It's really essential to get the equipment right. We will discuss the importance of being prepared for adverse events, because in both cases, things go quite quickly, and the earlier we detect issues, the more time we have to fix them. And finally, we will talk about optimizing the landing and recovery period. Gathering the right information is essential in skydiving. It's really important to know your drop zone, to know the regulation, to know the aircraft type, to know the emergency procedures, to know who's in charge. And as a skydiver, you should be well aware of the weather conditions. Of course, there is no discussion. If the weather is really bad, you should probably not jump from a flying plane. You should also know where to land, and that is similar to anesthesia. It is essential in anesthesia to know and flag the high anesthetic risk. As discussed earlier, the mortality in anesthesia is shockingly high, particularly when it comes to small animals. Depending on the studies and on the number of days in which animals are followed up after anesthesia, the risk is between 1 on 2,000 dogs and 0.7% of the dogs. And risk of death for healthy dogs, 0.05% mortality is in healthy dogs. In healthy cats, the risk is 0.1%, that is 1 on 1,000, and up to 0.6% in some more recent studies. So knowing that baseline risk for healthy animals, we also know from those studies that some factors are associated with an increased risk, meaning that when animals present those variations, the risk will be higher than what I've just mentioned above. So the factors we need to keep into account that are associated with an increased anesthetic death are animals that are pediatric and geriatric, obesity, extreme weights, extreme sizes, say a mini Chihuahua or a maxi Irish Wolfhound will have a higher risk than a medium-sized beagle, for example. The ASA status above 2, I will come back to that in a second. Unscheduled or emergency procedures carry a higher risk. And by unscheduled, I don't necessarily mean the procedures that are like emergency procedures. They are simply procedures that we do that were not planned on the day. So if you have an animal coming to the practice mid-afternoon and you want to squeeze in a very quick X-ray under general anesthesia, that animal, on the basis that this anesthesia was unplanned, has a higher risk of death compared to the same animal that comes on the day. You decide that you need to do X-ray, you plan your anesthesia for a following day or a day where it is actually feasible and manageable from your agenda point of view, and where it can be done in good conditions, where the risk will be lower in the second case. Abdominal procedure, orthopedic procedures, and neurosurgical procedures, as well as thoracic surgeries, are associated with a higher risk of death. And the longer the duration of anesthesia, the greatest or the highest, the higher is the anesthetic risk. So what can we do to minimize the risk? Well, we need to plan ahead, and that starts with a good physical examination and anamnesis. That is the key. I mentioned earlier that the anamnesis and preparation and essentially gathering the right information was essential to skydiving. Well, the same is true for vet anesthesia. Of course, in skydiving, the weather we had yesterday is not relevant if we want to jump today. And the same is true in anesthesia. It's not because the physical exam you performed when the animal came first to you 2 weeks ago was fine, is still fine today. So we need to have the anamnesis, make sure that it hasn't changed, and also make sure that we have a physical examination on the day of the procedure. Should we take bloods and should we do other bloods before anesthesia? Well, the answer is not a clear-cut yes or a clear-cut no. Any test like X-ray, ultrasound, cardiac ultrasound, ECG, etc. should be guided by the analysis and the physical examination and overall by the clinical picture. And without, well, we need to mention it, of course, the financial ability of the owners to pay for the test, but generally, it's highly recommended to do any test if you find abnormalities at the physical examination or in the anamnesis. Blood tests are not a substitute for physical examination. That means that you can do them on top of your physical examination, but you should not do them instead of your physical examination. The clinical relevance of bloods is debatable in young and healthy animals. Generally, it doesn't change too much what we do in anesthesia, provided that the animals are healthy. They can be relevant in young animals if we have no medical history. However, blood tests should always be carried each and every time you suspect an abnormality, either in the anamnesis or in the physical examination or both. Blood tests are essential in sick animals, highly recommended in geriatric animals because we know for sure that there is a higher incidence of concomitant diseases in the geriatric population, and those diseases may as well be subclinical, so we'd want to know about them before anesthetizing those animals. And finally, there are some considerations, like breed-specific considerations that can be taken into account, and that may guide a practitioner towards bloods or no bloods. I mentioned earlier that the ASA physical status was kind of linked to the anesthetic risk. So ASA stands for American Society of Anesthesiologists. It is essentially a description of different status from category 1 to category 5 in veterinary anesthesia, 6 in humans. And the purpose of that classification is to assess and communicate a patient's pre-anesthesia medical, the patient's pre-anesthesia and medical comorbidities. So ASA1 is a normal healthy patient. ASA2 is a patient with mild systemic disease. ASA3 is a patient with severe systemic disease. ASA4 is a patient with severe systemic disease that is a constant threat to life. And ASA5 is essentially a moribund patient. To ASA1 to 5, we can add the letter E, which denotes the emergency. And that means that when a delay in the treatment leads or could lead to a significant increase in the threat to life or to a body part. So if you remember, I've told you earlier that an ASA above 2, so that means ASA 3, ASA 4, and ASA 5 are associated with an increased anesthetic risk. There is quite a bit of evidence in vet anesthesia surrounding the ASA scoring, and we know for sure that veterinarians and nurses may disagree among them when scoring an animal. For example, I typically would score a routine stifle surgery as an ASA2, and one of my residents down here scores them as an ASA1. Does it make a difference? Probably not. What we know is I am very consistent in my scoring, and the resident is very consistent within her own scoring. The goal is not for all of us to agree on a set number, but really to assess and communicate the pre-anesthesia comorbidities. What conditions do we need to take into account? And also to help quantifying and stratifying the risk. Actually, there is a recent review in Frontiers in Veterinary Science looking at the ASA physical status classification and its relevance in veterinary anesthesia. And what was shown is that higher scores tend to be of prognostic value. So first message here, if you have to remember only one take-home message from the point 1, which is about gathering information, the full anamnesis is absolutely essential. A complete physical examination must happen on the day of anesthesia. You may require more tests and bloods before anesthesia, and that is generally guided by the clinics and the anamnesis. And the use of the ASA score helps communicating around anesthetic risk. Of course, we need to be aware that anesthesia carries a risk, and we need to know which types of patients are associated with a higher risk so that we can prevent the risk. Back to skydiving. The point number 2 is about planning and preparing. Communication around that phase is absolutely essential. In skydiving, it's essentially all about safety first and the right communication between the right people. Skydivers need to be in the right plane, at the right time, with the right team, know what they're expected to do because, of course, the time is very limited, things go very quickly, and incidents can be absolutely catastrophic. You can see on the picture on the right-hand side that there are about 14 skydivers jumping from that plane, which is the one I typically jump from back in France when it's skydiving season. We, of course, need to know when to get out of the plane so that we don't clash and become unconscious at a critical time all at the same time, that we have enough space and that we are close enough if we need to do things together. So communication there is absolutely essential. One of the key points in the consideration, in the preparation of anesthetic cases is actually the discussion of considerations. By considerations, we mean all the factors that we need to take into account that may have an influence on our choice of anesthetic protocol and on our choice of anesthetic equipment, and definitely that should have an impact on our communication surrounding a case that undergoes anesthesia. There will be consideration that will always be present for every type of anesthesia, say pain once you do a surgical procedure will always be quite high on the list of considerations. I am expecting some respiratory depression and some cardiovascular depression, and therefore I'm expecting a risk of desaturation, which is a risk of insufficient oxygen in the bloodstream. I'm also expecting a risk of hypoventilation, which is an excess of carbon dioxide in the bloodstream. And I'm expecting a risk of hypotension pretty much in every single case. In some situations, there are additional considerations. Say a case with liver failure may have low proteins, may struggle to metabolize the agents we are administering them. A case with, say, dilation torsion of the stomach may have already some respiratory issues before anesthesia and may have some cardiovascular impairments, may be very shocky, may be very vasodilated, and may need some specific adaptation in the case preparation. The case with mitral insufficiency will not tolerate an increase in the afterload. If I give too much vasoconstriction, I will increase the extent of the regurgitation within the atrium. Geriatric case may have osteoarthritis, may struggle to eliminate the drugs, to dispose of the drugs, etc. So for every case, we need to consider the normal anticipated complications of a routine anesthesia and whatever physiologic, pharmacologic change that is present in that animal and that is likely to have an influence on what we decide and what we pick as an anesthetic technique. In addition to the consideration, we also need to take into account the literature. There is some recent literature surrounding morbidity and mortality in anesthesia, and therefore surrounding safety in anesthesia. Better clinical assessment and pre-anesthesia stabilization are known officially to reduce the anesthetic risk. So make sure that the clinical assessment is well performed before anesthesia and that cases are stabilized before anesthesia, because that actually reduces the ASA score that is associated with a higher or lower risk. We know that using sedation lowers the anesthetic risk. We know that using decent, sufficient preemptive analgesia as well as local regional anesthesia lowers the anesthetic risk. We know that a long anesthesia is associated with a higher risk, and therefore we need to think that when we plan our anesthesia and be time efficient, work as a team on our workflow so that we can make the anesthetic event as short as possible, as long as necessary, of course, but as short as possible. And let's acknowledge once again the fact that quick cases and unplanned, unscheduled cases are associated with a higher risk. Therefore, we should really keep that in mind when it comes to adding a case to the anesthesia day, because that may come with an increased risk for that animal. So I said I had no conflict of interest. However, I'm still going to present you the anesthetic safety checklist of the Association of Veterinary Anesthetists. Not that I had any involvement in its development, because that was originally made far before I joined the association, even just as a member or as an anesthesia specialist. But I present it because it brings very important insights on how to manage safety around the anesthetic procedure, particularly focusing on the preparing and planning phase that we are discussing now. So this is a checklist that is found on the AVA website. The link appears a little bit later in this presentation, and you can find it just by Googling it. It is freely available and can be downloaded, hopefully by everyone everywhere. And you can use it because it's under a Creative Commons license. So you can really use it, print it, and use it in your environment. On one of the pages of the checklist, so it's designed to be printed front and back, and on one of the sides, there is actually a full section on pre-anesthesia and on the recommended procedure. In particular, talking about planning and preparing, there are a few questions that I strongly advise you to go through when you plan and prepare a case. Question 1, has anything significant been identified in the history and/or clinical examination? 2, do any abnormalities warrant further investigation? Hey, nothing new here, we've just discussed that, but this is also reported here in case I was too quick earlier and you want to have a physical support to remember about that. 3, can any abnormalities be stabilized prior to anesthesia? Well, We have just said that stabilizing animals before anesthesia would reduce the risk. Is there anything we can fix before anesthetizing those animals? 4. What complications are anticipated during anesthesia? Again, by anticipating the complication, we make sure that we spot them as early as possible, and the earlier we spot them, the earlier we fix them. Following question, how can those complications be managed? Well, again, I've told you earlier, we make really bad decisions when we haven't thought about them before. So let's think about what bad can happen during the event so that we have a drafted solution for when the event happens. Would the patient benefit from premedication? The recent evidence is in favor of using premedication because it's associated with a lower risk. How will anesthesia be induced and maintained? Do we need specific equipment, specific considerations? How will the patient be monitored? I'll come back to it in a second. How will the patient body temperature be maintained? We've mentioned earlier that hypothermia was generally a common consideration of anesthesia. Although I may have skipped that in my list, but I wish to add it now in case I have forgotten. How will the patient be managed in the post-operative period, post-anesthetic period? We'll come back to it because that's actually a phase of high risk. And finally, are the required facilities, personnel, and drug available? So you see, on that checklist, there is a list of questions that one should consider before even starting a case. And that's essential in the preparation and planning phase. I'm going to give you here an example that I believe is quite common in your general practice or in your daily routine. We'll talk about a 7-month-old male entire Yorkshire Terrier cross. The dog has no relevant medical or surgical history, no abnormality on physical exam, and is presented for castration. So this is how personally I approach an anesthetic case and how I plan for it. Things may well go very differently during the case, but at least this is how I build my plan. As considerations, I'd expect for this dog pain, hypoxemia, hypoventilation, hypotension, and hypothermia. I will set different goals for that procedure. So the premedication, as a goal, will have to have some preemptive analgesia, last the time of the procedure. I'm planning for an anesthesia of 30 to 45 minutes. Remember that I do work in a university teaching hospital though, so things may be faster where you work. I'd want my sedation to allow the placement of an IV catheter. So depending on the behavior of the dog, I may use different dosages. But for this case, for example, I could consider using methadone and dexmedetomidine. I will definitely intubate that animal. So for induction, I will need an induction agent, possibly titrated to effect. I'll probably use propofol. I would maintain anesthesia with isoflurane vaporized in oxygen and hope that the dog remains spontaneously ventilating. I will use a rebreathing system, make sure that my anesthetic equipment is well ready and tested before the case, and I will come back to it in a second too. I will make sure that I use forced warm air to mitigate the effects of the redistribution of the heat following induction of anesthesia, because that will drop my core temperature, and I don't want that to happen, or not to happen too much, because ultimately it will happen anyway. And I will use some fluids. My analgesia plan is divided into preoperative, intraoperative, and postoperative. My preoperative, preemptive analgesia is given by the methadone administered in the premedication. I'll consider for castration intratesticular blocks. If you remember earlier, we've discussed the fact that local regional anesthesia was associated with a lower risk, on top of increasing comfort and the journey of the animal within our hospitals. I will also use a little bit of local lidocaine to desensitize the scrotal area. Intraoperatively, if needed, if my premedication and my block are insufficient, I may consider additional full mu agonists, so methadone or fentanyl, if requested, if the animal responds to surgery. And postoperatively, I will consider meloxicam and maybe something else depending on regular pain scores. My monitoring for this case, planned ahead, I need a clinical monitoring because I know that most of the considerations and possible complications will be side effects of the drugs I administer that animal, and therefore I will want my anesthetic depth to be targeted to whatever it needs to be, but not too deep to avoid extensive side effects. And specifically to mitigate or anticipate the possible complications that I have listed earlier, I will use a pulse oximeter to monitor saturation. I will use a capnograph, either oscillometry or a Doppler and manometer to monitor blood pressure, monitor the ECG, and monitor the temperature. Supportive therapy, I'm aiming at monitoring the case throughout the procedure at a maximum every 5 minutes, but possibly continuously. And of course, I will continue my monitoring for at least 4 hours after the recovery. The supportive therapy is not expected to be much for this kind of cases, maybe a lot more for more complex cases. Take-home message number 2, use a checklist. One set of considerations per case. The best thing you can do if you want to increase anesthetic safety is, before jumping onto a protocol and a procedure, think ahead. Remember that things go really fast during the case and that we think poorly when things go fast and we are under pressure. We think better and we take better decisions if we have considered the events ahead of the cases. So for each and every case, I strongly recommend you to use a set, to think about the considerations for the case. Based on the considerations you have thought about and based on the anticipated complication, set goals to your anesthetic protocol. By goals, I mean, what degree of sedation do you need? How many agents do you need to take into account in your multimodal analgesia protocol? How will you manage a poor recovery? How do you anticipate the animal will behave during the recovery phase, etc.? The protocol, actually talking about drugs, drugs are a really small part of anesthesia, and all the steps around the anesthetic management are actually more important than the drug choice per se. But the protocol in terms of drugs and in terms of side management of the case should reflect your goals and the elaboration of a plan following a careful establishment of the list of considerations. We have enough evidence to mention that cases should be stabilized before anesthesia. Therefore, do not rush into anesthesia. Stabilize your cases. Make sure that they are sedated, pre-medicated, and that each and every time you can, you use local anesthesia. Now back to skydiving again. Well, I think you'll all agree with me that regardless of your interest in skydiving, you would not jump from a plane without a working parachute and without a plan B. So actually, the equipment is essential in the skydiving discipline. People always have a main canopy. Believe it or not, they always have a second canopy in case things go wrong with the first one. And they also have automatic activation devices that are known under the acronym AAD, and those are designed to actually fire and make sure that even if you are unconscious, quite close to the ground, there will still be a wing over your head before you touch the ground. Getting the equipment right also implies that you check it. No skydiver would board a plane without checking their own equipment. You need to check the equipment before actually wearing it, when you wear it, before boarding the plane, and during the ascent. Of course, it's too late to check it when you are in the free fall, and the same is true in vet anesthesia. You don't want to have to check your anesthetic machine once you are in the maintenance phase. You need to have the equipment right, and you need to have it checked before you actually need to use that equipment, because time is precious. So what do we need? Well, getting the equipment right in anesthesia pretty much depends on the techniques you are using and on whatever your plan is. So I can't really give you much information at this stage. The only thing I can tell you is, first of all, that in 2024, it is probably not acceptable anymore to perform anesthesia without any oxygen supplementation. Getting oxygen nowadays is like fairly easy. You can have oxygen concentrators and they are quite cost efficient. You can have cylinders, you have plenty of different options. Oxygen should always be at least available when you perform an anesthesia, regardless of the type of anesthesia. So before a case, make sure that you have enough oxygen, that your oxygen source is actually working and carries sufficient oxygen for whatever you need to do. If you need an anesthetic machine, which personally I use every day on pretty much every single case, make sure that the machine is assembled. Unlike in the picture here, you can see that on my picture on the right-hand side, I have a beautiful RWD machine, but I have actually not a reservoir bag connected to it. I have no breathing system. My oxygen concentrator below is probably not connected to the machine. At least I can't see any tubing going out of it. So this is actually not an optimal setting for anesthesia. Make sure that your anesthetic equipment is assembled and tested ahead of the game, and certainly before you need. We said at induction of anesthesia, generally we will intubate the trachea. Make sure that you have the necessary equipment for induction. I know it sounds a bit trivial to say that, but how many times have I seen people running for a laryngoscope when they needed one? Because in most of the cases, they don't need to use a laryngoscope. And on the one I was observing, guess what? They needed one. And it was in a completely different room. Blue animal desaturation, increased risk. We don't ask them to read and write before anesthesia, and that's probably lucky because I'm pretty confident that we lose some neurons in this kind of events. Make sure that you have your laryngoscope for every single induction. We make sure that it is bright and tested, and make sure that you have handy every bit of equipment that you will need for the case. Also, depending on the physical examination, be prepared for possible difficult intubations. We expect a difficult intubation in brachycephalic breeds, but also in head trauma, in facial swelling, in animals that may have oral masses, that may have laryngeal paralysis, that may have abscesses around the neck area, that may have salivary glands or tumors in the neck area, in the chin area, and so on. There is a list of cases in which the intubation could be difficult, and we need, as anesthetists, to be prepared for a difficult intubation because the time of induction is very critical, and we need to intubate the animals to, number one, monitor, and number two, control the ventilation if we need to do it, which is highly likely when we use anesthetics because they are very potent respiratory depressants. Any dog with signs of obstruction at physical exam, with increased respiratory sounds, with increased respiratory efforts, etc., that may come from an upper airway obstruction should be considered as a candidate for a difficult intubation. For example, in a normal intubation, I'd prepare 3 ET tubes, one of the size I expect to place, one above and one below. How do I decide the size I'm supposed to place? Personally, I palpate the trachea and guess which size I will need in that animal, and I get half or one size above and one size below that. However, in those difficult intubation cases, like brachycephalic that are known to have a hypoplastic trachea, I will want to prepare at least 5 ET tubes, make sure that I have all the pre-oxygenation equipment so that I can pre-oxygenate them and maximize the time between the induction and intubation, and that I prevent a too early desaturation if I can. So this is an example of toolbox that I routinely use in the clinics and that I generally bring with me when I change workplace. This is a difficult airway box. It's a very compact, easy toolbox, cheap. You can get it everywhere in every shop. Like doesn't have to be veterinary specific, and it contains the equipment that may be needed to manage a difficult airway. The advantage is that you can carry it in different places of the hospital so that you can use it for induction of anesthesia during recovery and so on. For example, it contains a large set of cuffed and uncuffed T-tubes. It contains wires, guides, brighter laryngoscopes, smaller tubes, catheters, tracheotomy kit, laryngeal masked airways, etc. I may work in places that have challenging caseloads and maybe a bit of a more challenging caseload than what you'd see on a routine basis. However, I'm pretty confident that this tool should be available in most places. And I can say that I have used the difficult airway box at least 2 to 4 times per year in the last 7 years, and it has saved my ass literally at least twice a year in the last 6, 7 years. So this is a tool I really like, and I strongly recommend you develop and implement in your environment. Again, getting the equipment right is listed in the safety checklist of the Association of Veterinary Anesthetists. So primary oxygen should be checked, backup oxygen should be available. If there is an oxygen alarm, it should be in adequate working status. The flow meter should work. The vaporizer should be attached and full. The anesthetic machine should pass the leak test. The scavenging should be tested and checked. If you are using passive scavenging, you have to weigh the fluid absorbers. Make sure that you do that, because safety of people around anesthesia is also quite essential. Make sure that you have anesthetic monitoring equipment, and make sure that you have emergency equipment prepared. Regarding the drugs and equipment, we've discussed endotracheal tubes, we've discussed airway aids. We haven't discussed, but I'd strongly consider having self-inflating bag or equivalent in your environment, making sure that you have your emergency drugs ready, that you have intravenous cannulas, fluids, and that you are ready for a potential CPCR. I think on the top, I'm not sure because I have actually pictures of, no, I don't have it here, sorry. I probably have it later, but make sure that you have the equipment you need on hand, that you don't neglect the equipment, and that you have your emergency drugs calculated and available, that even if someone else has checked your anesthesia equipment, you double check it and make sure that you have enough oxygen for the procedure. Again, remember, nobody would jump from a flying plane without a parachute and a rescue parachute. So make sure that our anesthetic equipment is ready and fit for purpose. Fourth point, preparing for adverse events. Well, we have discussed the considerations, and certainly in skydiving, the risk is quite high and happens quite quickly. Essentially, in skydiving, at a certain altitude, the parachute must be deployed and controllable. You want to have above your head a canopy that is in working status and that can bring you where you want to go to land. That means that, first of all, you monitor your altitude, because it will be risky to open the canopy too low and too close to the ground. We want to do that at a set altitude. We need to monitor throughout the fall the altitude. And we also need to recognize side effects or events that may make our canopy uncontrollable. So we need to know the various deployment abnormalities or anomalies, know what to check, so that in the unlikely event of an abnormality and us having a non-controllable canopy over the head, we still have time to change it. We need to be prepared for adverse events. Well, the same is true in anesthesia. And guess what? We've just spent quite a few minutes now talking about the possible considerations. Considerations would be useless if we do nothing about it. I've told you earlier, we need to monitor so that we detect the complications actually as early as possible. So monitoring in anesthesia is really critical and essential. Most of the side effects, or most of the complications we'll observe under anesthesia, will come from side effects of the drugs we use. Therefore, we need to make sure that we use as little drugs as possible so that we can get what we need to do. We can do what we need to do without overshooting our anesthesia. Monitoring of anesthetic depth is absolutely essential. However, that's not all. Yes, we monitor the palpebral reflex, the jaw tone, the presence or absence of movement, of reflexes, etc. But we also should monitor the pulses, the capillary refill time, the mucous membranes color, etc. And we may need to auscultate the animals during anesthesia. That is part of the clinical monitoring. In addition to the clinical monitoring, and not because RWD is sponsoring this webinar, but because this is absolutely true and demonstrated. We need to use instrumental monitoring, and I'm not telling you which. This is your call. But within the instrumental monitoring, we'd recommend to use routinely and pretty much on every single case, at least pulse oximetry, if possible, capnography and some indicator of blood pressure as well as temperature. If you have capnography available, it's probably a good idea, and ECG as well. Not only should we monitor, but we should also record what we do and record what we monitor. It's essential to monitor anesthesia and to have an anesthetic record. This allows us to hand the cases over if needed. This is a legal document. If you have any issue and you are brought to court with one of your patients, you may be able to document through a decent and good anesthetic protocol that you have done everything in your power to anticipate the complications and to deal with them if they present. And all in all, once an animal is awake and pain-free and has left the hospital, well, actually, the only trace you leave of the good quality of your anesthesia on the planet, provided that the animals are walking away from the hospital, is actually a good record. Again, this is an example. You don't have to use that record. This is one I use on a regular basis. This is an anesthetic record that can be downloaded for free and printed from the AVA website, and the address. You can do screenshots right now. The link to the anesthetic record as well as the checklist is found on the bottom right of this screen. I'd strongly recommend you to start using anesthetic records if you don't already, and I strongly recommend you to use the checklist or at least one form of checklist if you don't already. Message number 4, take-home message, keep anesthesia short. Oh, this is where I have the emergency drugs. You see, I thought I had it on the previous section, but I actually have it here. As discussed, you need to anticipate the complications, and that comes with a decent monitoring of the complications. The soonest we treat the complications and the less we'll have to intervene. So it's important to detect the complications early and to treat them early. So one thing I like to carry with my cases is a little box that contains the emergency drugs I may be needing for every single case before even thinking about premedicating them. Believe it or not, I, as an anesthesia specialist, will calculate the volume of adrenaline, atropine, lidocaine, glycopyrrolate I need for this case in case of adverse event and in case of CPCR. Not only will I do that, I will know exactly in case of adverse events how much volume to administer to those cases, but I will also carry the little blue box you see on the top right corner of the screen here, which is my emergency drug box. For every patient, from the time of premedication to after the recovery, I will have that box in proximity because we know for sure that when we have an adverse event and we need to treat it, or when we have a cardiac arrest and we need to do CPCR, we need to be time efficient. And by having the drugs volumes pre-calculated and drugs available on the side of the animal, we are actually much, much faster than if we have to run to another place to get them. Again, monitor. The sooner you identify an issue, the easier it is to fix. Last but not least, and I promise you I'm nearly done with all the safety, well, we need to optimize the recovery phase. I told you earlier that the injury rate is lower in skydiving than the lowest mortality rate in vet anesthesia. However, there is strong evidence to suggest that most of the incidents in skydiving happen during the landing phase. And guess what? In anesthesia, most of the mortality happens during the landing phase, which is the recovery period. So in skydiving, we need to optimize the landing phase. We need to know how to avoid collisions. We need to know how to get where we want to land and how to land there safely. Again, safety is a collective effort, so you and your fellow skydivers need to know what you are doing, in particular at that phase where there is a high chance of collision. The risk of death in vet anesthesia is higher than in human anesthesia, and we have evidence suggesting that the highest risk happens during the recovery phase. 47% of dogs, 61% of cats, 64% of rabbits will die that died around the anesthetic period will die during the recovery phase. That percentage goes to up to 70% in most recent studies. And when will they die? Well, probably in the first 24 hours following anesthesia. Why will they die? Because of a lack of monitoring. Keep in mind that an animal in recovery is too conscious to be fully controllable. If they are extubated and moving, we cannot control the end-tidal CO2, we cannot ventilate for them, we can hardly monitor the blood pressure and hardly monitor like all the variables we want to monitor during an anesthesia. However, they are still under the effect and the influence of anesthetic drugs and will take some time for them to get rid of them. That means that the risk of complication is still very likely. And the reason why the mortality is high during the recovery phase is simply because we don't monitor them sufficiently. So what should we do to increase anesthetic safety? If you have one thing to remember from today's presentation, we should monitor our recoveries, and we should do that until it is safe to transfer an animal. When is it safe to transfer an animal after an anesthesia? Personally, I consider that we can move an animal away from our vigilance when the saturation is above 95% and when the animal is standing or at least in sternal recumbency and when that animal is responsive and when the Glasgow Composite Pain Score or whatever tool you are using to assess pain is below 4 out of 20 or 5 out of 24 for the Glasgow Composite Pain Score, because I know that using this system, if I have a higher score, I will need to administer rescue analgesia. But if you use other systems, you may have other cutoff values. At least consider that the animals should be comfortable and that temperature should be above 37. And if there is a place ready for that animal in the next location, and if a proper handover is possible. So you see that I will stop monitoring my animals, provided that I match all those conditions. And yes, that will take time, but that will definitely contribute to increased safety. So take home message number 5 from me today. Monitoring recovery is absolutely essential. Postoperative analgesia should be continued. And because recovery is the high-risk phase, this is probably where most of the effort should go. Takeaway messages from me today. We can all together, through few small measures and changes in habits and good communication, reduce the anesthetic risk. We can do that by taking decisive steps towards safer practice. One example is using a checklist, but you have had many other examples in the presentation today. And because it's useful to implement the changes when they are fresh in your mind, personally, I'd recommend as an action point to start with 3 small changes as of today if you are still working, or tomorrow if you have finished your working day. And that's nearly all from me today. So how to enhance anesthetic safety through strategic case preparation? Well, prepare, plan, communicate, have the right equipment, stabilize animals before anesthesia, use checklists, use sedation and local regional techniques as much as possible whenever you can. Be prepared for the adverse situations. Remember, we don't think well under pressure as human beings, and monitor your recoveries. So I hope it was helpful, and I will be happy to take questions if you have some for me. I'll just check the chat because I haven't seen it today. Oh, I see one question. Hi, what do you recommend for your doses for pre-medication? From Alexandria. Ooh, that is a very difficult question. What do I recommend? So I can't really make a big recommendation for pre-medication in general on the basis that I will adapt my pre-medication for every single animal. how do I choose the drugs? Well, I essentially make a list of considerations for that patient and set goals. That is, what duration of procedure I expect, how painful will be the procedure, how long will it take, etc. What's the behavior of that animal? Is the animal staying in the hospital or going home today? And so on. And depending on the behavior of the animal, of the presence or absence of concomitant diseases, then I will adjust the drug choice and the dose. So I'm sorry, it's not very helpful, but that's the normal approach. However, if you, I mean, of course, it also depends on where you are working from, because some countries may be limited in what drugs they can access, and there may be some local legislation that guides you towards one direction. So it's a really hard question. Second question, how do you differentiate a waking animal from a code? I am not sure I understand the question. Can you expand a little bit, please? The following question is there any minimum age for old patients for gas anesthesia? Like if the patient is 6 years old and above, for routine spaying, safe for gas anesthesia instead of injectable drugs? I don't think there's an age limit. Generally, there are no cutoff values, and I tend to consider that unless very few cases, gas anesthesia is generally a valid option for most patients, really. Hello, doctor. Let me introduce myself. I'm from Deborah from Indonesia. I want to ask about castration operation for dogs and cats. Is it safe to use just local anesthesia with lidocaine? And is it better to use local or general anesthesia for castration surgery? Personally, for a castration, I'd use anesthesia, general anesthesia, and a local regional technique. If I were not to use general anesthesia, I at least use a deep sedation. I am uncomfortable with just local anesthesia on those procedures on the basis that the local anesthesia we can do for a castration is generally imperfect and will lead to some degree of pain in these animals. So because it's imperfect, they need to be at least unconscious. At least that's how I see it. So I wouldn't do just local anesthesia. I would do either very deep sedation for cats, general anesthesia for cats, and most likely general anesthesia for dogs, and generally general anesthesia for cats too, and a local regional anesthesia. Any tips on selecting an oxygen concentrator to use for anesthesia? This is also a very hard question because it pretty much depends on where you are, what you have on the market. I suppose as long as the machine does the job, which is delivering above 95% of oxygen and is cost efficient, you can probably be happy with it. But I can't make you a general recommendation on how to. Just make sure that the machine does what it's supposed to. Next question. What is the first step to take when the SpO2 is below 75%? Well, when the SpO2 is below 75%, the first step would be to make sure that you provide oxygen to that patient. So I'd say if they are not intubated, intubate them, make sure that you deliver 100% of oxygen, that you manually ventilate, or that, I mean, you provide them oxygen, that the oxygen is actually reaching the lung. So first step, always assume that your reading is true, even if it isn't. Get a as high as possible inspired fraction of oxygen. Make sure to administer oxygen to those patients. And then troubleshoot to see what was the cause of it. Next question is, if I have no inhalator in the clinic, what can I do soft tissue surgeries, and what's your recommendation? No, I use the combination of xylazine, atropine, ketamine for each. Oh, Ahmed, this is a very difficult question too. it depends on what you do soft tissue-wise, how invasive your procedures are. I would say I would definitely use oxygen on top of that protocol, and if possible, I would increase the analgesia component of your protocol. That means that I would prefer to have, if compatible to life wherever you are in the world, and if you have access to opioids, I'd like to see an opioid in that protocol. Personally, I don't like mixing atropine with an alpha-2 agonist like xylazine on the basis that the bradycardia you see with xylazine is actually a reflex bradycardia because of the vasoconstriction caused by the drug, and therefore you probably don't need to increase the heart rate using atropine when the low heart rate comes from the xylazine. So I would personally remove the atropine component of that protocol, add some analgesia, at least local analgesia wherever you can, and possibly an opioid if you have access to one, and make sure that as a bare minimum, you administer oxygen to those animals. If you want to make your cases safer, I'd always recommend an IV catheter placement and orotracheal intubation. Personally, I would not be really happy to have major soft tissue surgery without an IV catheter and without an ET tube and oxygen. Whether you use volatile anesthesia or injectable-based anesthesia, we can discuss around, but in terms of safety, I'd always consider at least oxygen, IV access, and more analgesia. Next question, can you recommend anesthesia protocols for cardiological patients? Unfortunately, I can't because different pathologies will have different goals. For example, if I were to consider cats with cardiac problems, the most likely issue in cats will be a hypertrophic cardiomyopathy. In that case, I may want to increase a little bit the systemic vascular resistance so that I have a more laminar flow and a lower heart rate. And I increase the chances of my myocardium to be perfused and of my blood flow to be laminar. And therefore, I may want to consider some alpha-2s in some cases in cats with hypertrophic cardiomyopathy. If I now take what's most common in dogs, which will be a mitral regurg, in that case, I really don't want to have any increase in the afterload because that will increase the amount of blood that is refluxing from the left ventricle to the left atrium. And therefore, I will target a reduction in the afterload, which is exactly the opposite as what I would aim for in a cat. So generally for cardiological patient, I'd recommend you to check specifically what is likely for that patient. Say, is it a hypertrophic cardiomyopathy? Is it probably a congenital anomaly? Is it a mitral regurg? And specifically target your drug choice to the considerations and the goal you set for your cardiovascular system facing this cardiological issue. If we use butorphanol for pre-medication, can we use buprenorphine 2 hours later after surgery for postoperative analgesia? And the answer is yes. Butorphanol will not last very long. It will last 30 minutes to an hour maximum. And buprenorphine should still be able to provide you with some analgesia after butorphanol, provided that you don't give them at the same time. I'd consider buprenorphine from about an hour after butorphanol. If we have a patient with chronic kidney disease, what precautions can we take to mitigate the risks? So make sure that your patient is well hydrated before anesthesia, normovolemic before anesthesia. Depending on the degree of chronic kidney disease, they may come with a huge variety of presentations. They may be PUPD, they may not be PUPD, and I'm not sure where you live. Personally, currently, I'm in Western Australia. It's quite warm, and if I have a PUPD animal that comes in the morning and it's already 30 degrees, then the animal may be dehydrated before anesthesia. So on a patient with chronic kidney disease, I would want to make sure that they are euvolemic before anesthesia and that I administer sufficient fluids to overcome the possible excess loss they have. I'd want to make sure that I have no electrolytic abnormality, and I would want to make sure that I don't rely too much on drugs that are eliminated by the kidneys because they may be present in the animals for much, much, much longer than in an animal that doesn't have chronic kidney disease. I'd also want to make sure that my blood pressure throughout the case is adequate so I maintain splanchnic perfusion and therefore kidney perfusion, glomerular filtration rates, etc. So make sure that you don't have too much blood pressure drop during the case. Make sure they are euvolemic before, during, and after the procedure. Check the electrolytes, possibly before, if necessary, during, and definitely after the procedure. Make sure that you adapt your fluids to whatever you are doing, plus the increased possible loss. And make sure that you have a very good analgesia protocol on those cases because they may suffer from an increased in blood pressure because of sympathetic activation. For pre-medication, if we use medetomidine and butorphanol, can we add ketamine and midazolam for better anesthesia? It depends on the dosages. Generally, ketamine will probably be enough. You don't need the midazolam on top of it, but in some cases, it may be helpful. Do you give NSAIDs before or after surgery? This is a very debatable question. The risk of the NSAIDs beforehand is that if you have a hypotensive event during the procedure, you will not have the prostaglandins that are used in the kidney to maintain the glomerular filtration rate as constant as possible facing a hypotension, and therefore you may have kidney perfusion impairments. Normally, we monitor blood pressure during anesthesia, and we treat it aggressively whenever it develops. So we should not rely on those prostaglandins, in which case it's not a big drama to give NSAIDs beforehand. However, if you expect a bleeding, if you are not sure, if you may need steroids in recovery, say, for example, a brachycephalic animal that may need steroids in recovery because they may be swollen in recovery, may have a swollen airway, etc., then you may hold on a little bit on the non-steroidal, definitely give them post-operatively. Next question. I'm a veterinary anesthesiologist from Taiwan, and I am wondering if you ever experienced a situation where the canine feline patient recovered from anesthesia quite roughly. How do we differentiate the cause and manage this situation? Oh my dear, the answer to that question is yes, definitely. And there is actually a very recent paper in the Journal of Veterinary Anesthesia and Analgesia looking, I think it comes from the University of Liverpool, and it looks at the incidence of bad recoveries from anesthesia. It is fairly hard to differentiate the cause. My personal approach is generally, I assume that it could be pain and treat pain because that is the worst that can happen. And if by treating pain, I don't treat the problem, I will add some sedation. Sometimes I will do both at the same time, meaning that I will increase my analgesia and give some sedation because it's quite stressful for the animals and quite stressful for the staff around those animals. So yes, animals do recover from anesthesia in a rough fashion quite regularly, even if you do a perfect job. No magical recipe on that front. And yes, it's quite hard to differentiate. Do you recommend giving kidney medications prior to surgery for CKD patients? If so, how long before the surgery? I'm not sure if you are a general practitioner or a different or have a specific specialty. I must say I do respect a lot general practitioners. You are superheroes to me, guys, because you know and do so many things, and I can do only anesthesia, and I have no competence whatsoever out of anesthesia. My personal approach when it comes to patients that have chronic kidney disease is that I don't feel I have the legitimacy to add or change the treatments that someone else leading with the chronic aspect of the case has decided. And therefore, generally, if those patients are on drugs, either from their general practitioner or from internal medicine, I consider that I have no legitimacy to interfere. So I will not add much, but I will not remove the treatments. If I have a doubt and I'm not happy with the animal and I need to stabilize it before anesthesia, I must say most of the time I will refer that animal back to internal medicine where it belongs if anesthesia can wait. So I'm sorry it's not the most helpful answer because it's not a black and white one, but personally I don't interfere too much with the medications other than sedation and analgesia prior to the cases. Do you administer corticosteroids prophylactically pre-op for brachycephalic breeds? I don't. I keep them on hand for the recovery if necessary, and if I can stay away from steroids, I will probably and most likely use non-steroidals in those animals post-operatively. So those are all the questions that are in the Q&R box, and I see a few more questions in the chat. So let me get back to those. Do you use medetomidine or dexmedetomidine differently, or do you think they are similar? Well, they can be used, you can use one or the other, and I have no personal preference. They will be the same volume, so you just have to adjust the dose. I'd say clinically they are quite similar. There are maybe a few cases in which I'd prefer dexmedetomidine to medetomidine, but that is based on drug concentration and drug volume. Depending on the countries, you will find most of the time medetomidine, which is 1,000 milligrams per milliliter, and dexmedetomidine, one milligram per milliliter, sorry, big one, 1 milligram per milliliter medetomidine, and 500 microgram per milliliter dexmedetomidine. But you may find 100 microgram per milliliter dexmedetomidine that is licensed in your country, and that would come with a volume that is easier to manage in small animals. So say in small cats, I probably would prefer dexmedetomidine if I have the 100 microgram per milliliter concentration wherever I'm working. Otherwise, if I have no drug concentration issue or possibility, I don't care. Pre-medication, how fast could it be? Is 15 minutes reasonable? Well, that is very difficult too. It depends on the drugs you are using. If you are using acepromazine, then 15 minutes is probably insufficient. If you are using acepromazine intramuscular, you probably need to wait 30 to 40 minutes. And if you are using acepromazine intravenously, you may need to wait 20 to 30 minutes. If you are using alpha-2 agonists, it depends again on the dose and on the route of administration. But generally, I'd say 15 minutes on the paper is not unreasonable. What differences do you consider to choose methadone or fentanyl in the pain control intraoperatively? Methadone will last for 4 hours and fentanyl will last for 20 minutes. Both are titratable to effect. If I need a lot of the opioid, but I don't expect to need it for very long after, I will probably go for fentanyl. If I need some more opioid and I expect to need it after, I will probably lean towards a longer lasting one like methadone. This is Monica from Indonesia. Have you experienced administering anesthesia to exotic animals? Because sometimes, aside from dogs and cats, exotics could come to the clinics as emergencies. Yes, I have quite some experience with exotic animals. I do. I'd say you would have to discuss which species and which context because there is a lot to talk about around this topic. Good, good, good. And I think, oh, there is one more question. Oh, no, it's the same in a different place. So I think we are done with questions unless anyone has more to ask.
Okay, thanks again, Dr. Matthew. Vet is a reverse distributor, and AUE could provide products you need on anesthesia and recovery industry. So if you have needs, just contact Vet. And this brings us to the end of today's webinar. If you need more information, you can either send us email or follow our social media accounts as shown in the screen, and we will announce our next academic on it. Thank you. Thank you very much.
Thank you for having me, and have a nice day or night, everyone.